Alors bonjour, je m'appelle Alex, au nom du regroupement québécois des maladies orphelines. Il me fait grand plaisir de vous accueillir à ce webinaire. Fondé en 2010, le regroupement québécois des maladies orphelines, RQMO, regroupe des patients, des proches et des associations de maladies rares. Rappelons d'ailleurs que pour être considérée rare, une maladie touche typiquement moins d'une personne sur 2000. Notre mission est d'offrir un service d'information et de soutien sur les maladies rares via notre centre e-rare, faire circuler l'information sur les maladies rares au sein de la communauté maladies rares, sensibiliser le public et le milieu médical aux maladies rares et à leurs enjeux, qui sont nombreux, et favoriser l'avancement des connaissances et de la recherche sur les maladies rares et orphelines. Si vous désirez soutenir la mission du RQMO, que ce soit le fonctionnement de notre centre e-rare, notre série de webinaires ou nos autres activités, je vous invite à faire un don en accédant au lien au bas de l'écran. Vous aurez alors l'option de faire un don par la poste ou en ligne via notre page Canadon Canada Helps. La conférence d'aujourd'hui porte sur la manifestation osseuse du syndrome d'Ehlers-Danlos et sera donnée par la Dr Shuaa Basalom. Généticienne clinicienne avec un intérêt particulier pour la dysplasie squelettique et les maladies du tissu conjonctif, son intérêt pour les maladies du tissu conjonctif provient de son expérience personnelle d'avoir étudié une maladie génétique qui n'a pas été diagnostiquée. La Dr Basalom a fait ses études de premier cycle en Arabie Saoudite et a terminé sa résidence en génétique clinique à l'Université McGill. Elle a également fait son stage en génétique des maladies osseuses à l'hôpital Shriners pour enfants Canada. Actuellement en congé de maternité avec sa petite famille à l'île du Prince-Édouard, son objectif est de créer une clinique de tissu conjonctif. Son plus grand rêve serait d'établir un centre d'excellence en tissu conjonctif au Québec. Dr Basalom, merci beaucoup d'être avec nous aujourd'hui. Thank you so much for joining us today. It's lovely to see you. Avant de vous céder la parole, j'aimerais simplement indiquer que la présentation sera suivie d'une période de questions. J'invite les spectateurs à soumettre leurs questions au fil de la présentation en utilisant la fonction Q&A, questions-réponses, qui devrait se trouver au bas de l'écran. Enfin, pour ceux et celles désirant profiter de la traduction simultanée, je vous invite à sélectionner votre langue dès maintenant au bas de l'écran. Alors, sans plus tarder, Dr Basalom, à vous.
Thank you, Alex, and thank you for the invitation. I'm really thrilled to be joining you, although it's virtually, but we're still together. So just before we start, can I have an idea how many of the attendee are patients? Can the patients raise their hands, please? Screen.
So 19 people so far.
So 19 people are patients. So how many healthcare professionals are there?
Hold on, it's just changing.
Je suis MD, okay. Good.
Yeah, so there's maybe about 10 to 15 professionals if we go based on the hand raising that we see there.
Okay, good. Okay, so we'll start. Okay, so today I'm going to talk about the bone finding, Ellardano syndrome. In my talk, I'm gonna have a quick review about the Ellardano syndrome to start, and then I'm gonna talk more about the bone findings first and the most common types of EDS, and then on the more rare types of EDS, and then I'll go through some recommendations about managing and dealing with these bone findings. So first, I'm sure most of you know this, but just as an introduction, so what are the Ehlers-Danlos syndrome? So they are a group of connective tissue diseases. They have common features for all the subtypes, and which are the joint hypermobility, which means like the joint that stretches further beyond the normal, skin hyperextensibility, and tissue fragility. And basically, the tissue fragility can affect any tissue in the body, like the vessels, the skin, any whole organ, the GI tract, the uterus. It depends on the type of the Ehlers-Danlos. So these are the types of Ehlers-Danlos syndrome. So as many of you might know, that the Ehlers-Danlos syndromes has been reclassified in 2017. So after 20 years of the last classifications, so now we have 13 clinical diagnosis of Ehlers-Danlos syndrome with 19 genes. I'm not gonna go through each and every one of types, just to have a general idea. So the most common type is the hypermobile EDS, which used to be called type 3 Ehlers-Danlos. So the good thing that's in the new classification, we kind of get rid of the number. So we don't say type 3, type 5, type 2 anymore. We go with the clinical description. So the most common types are hypermobile, which represent about 90% of the Ehlers-Danlos syndromes, and then comes the classical EDS. And we have so far 19 known gene, but the most common type, which is the hypermobile, does not have a known gene yet. So what's joint hypermobility? So this is one of the most common sign that we have referral because of that. So they have lots of referrals saying patient is hyperlax, patient has joint hypermobility, please rule out Ehlers-Danlos syndrome. So the joint hypermobility is the capability of the joint to move beyond its normal limit. We know every joint is our body has specific like angles, and we call it so some can, if there's joint hypermobility, these joints can go beyond the normal angle. So the patient will come and say, I'm very lax, I'm hyper flexible, I'm double jointed. The kids sometimes they say, oh, I'm very good in gymnastic class. I can do tricks for my friends, and they start showing us how flexible they are. And this can be an isolated finding without being part of a big syndrome or a bigger condition, or most of the time it's a part of a larger diagnosis. So because joint hypermobility, it's a very common finding, like it could be just a normal variant. So a score was developed to have it assist more objectively. So there's something called a Biota Score. I'm sure most of you have heard about it before. So we give a score from 0 to 9 to determine how flexible this person is. So so it's to extend the little finger beyond 90 degrees. So it's 1 point per side. We have to pull the thumb back to the forearm. This is another 1 point per side. We have to extend the elbows and bend the knee backwards. It has to be beyond 10 degrees, and we'll ask the individual to touch the hands, to touch the floor with his hand without bending the knees. So usually if the person has a score above 5, we saw this is a positive Biota score, and this person is flexible hypermobile. Recently, with the new classification, we changed the scoring system a bit. So for prepubertal, so for children, it has to be more than 6 to be positive. Because like children are flexible naturally. And in one study, it's up to 18% of children, they have positive Biota score, and not EDS children, just the regular children. So it's very common in children to be flexible. And then with aging, we get more stiff naturally. So above a certain age, we need only more than 4 scores to have a positive results. Just a little comment, the Biota scores, there are some papers out there about the efficacy, like how sensitive it is, and do we really need to do it? We might induce joint dislocation or affect the patient because ask him to doing that, but this is out of the scope of my talk. So because the joint hypermobility is really common finding, and many of the patients that we see, they don't have enough clinical signs and symptoms to fulfill the criteria of a hypermobile Ehlers-Danlos. So the new trend now is to describe the conditions in a spectrum from mild to moderate to severe. Or here, so in joint hypermobility, so we have generalized joint hypermobility, localized hypermobility spectrum disorder, peripheral hypermobility spectrum disorder, generalized hypermobility spectrum disorder, and hypermobile EDS, which is the full-blown Ehlers-Danlos syndrome with so the person has to have fulfill a specific criteria to have this diagnosis. So they are all just like names we give a patient to have an official diagnosis, but the point is the person have something, but it might not be Ehlers-Danlos syndrome like full blown, but it's not within the normal, like he does have, he's more flexible and he's more hyperlax. So the hypermobile Ehlers-Danlos syndrome, as we said, it's the most common. It represents up to 90% of all the Ehlers-Danlos syndromes. And as I said, also there is no single gene has been identified yet, although there are a lot of studies. There's a big study now ongoing. It's by the Ehlers-Danlos Society and doing whole exome sequencing on hundreds of patients trying to identify the gene for EDS. And already many studies have been done before. It's most likely going to be like a multifactorial or complex inheritance, like in diabetes and hypertension, when we know there is genetic factor, but we cannot identify a specific one gene, like it's not a single gene disorder. So clinical features, I'm not going to go through the criteria and the major criteria and the minor criteria. It's not the scope of my talk today, but generally speaking, it's really a multi-systemic diagnosis. So the patient could present with pain, and the pain could be really severe. They have skin changes, like skin easy bruising, like thin skin, abnormal scarring. I'll show some pictures later. They could have some like skin bumps, they called pseudotumors, or they could have like cigarette-like skin. So they could have stretch marks or striae. Fatigue, again, is very common, and many patients get misdiagnosed with just like polymyalgia rheumatica or fibromyalgia. Many get misdiagnosed of fibromyalgia because the pain and the fatigue. Digestive problems are common. Dysautonomia, so problems with micturition and passing a stool. Headaches. Osteoarthritis, they could have early onset osteoarthritis. They could have temporomandibular joint and dental issues. Sleep disturbances and sleep apnea is common. Mast cell activation, so they could present a picture similar to allergy. Psychiatric manifestations, and I mean like anxiety and depression is more common during among these patients. I don't mean that EDS is in your mind, or no, it is a real disease. And because of having this condition, you might be more prone to develop psychiatric symptoms. The classical EDS, again, they have a lot of overlapping finding, but the classical is a bit, it have more prominent skin finding, and they could have also vascular, a bit of like a vascular component, but it's here the skin, it's more prominent than the joint, but they overlap a lot. So the classical EDS, they could have skin hyperextensibility, abnormal wound healing, joint hypermobility. And here we have identified a gene. So more than 90% of individuals who have classical EDS have mutations in collagen 5-1A or collagen 5A1 or 5A2. And it's inherited in autosomal dominant manner, meaning we need only one parent to be affected to inherit this condition. So this is a picture from the article that represent the new classification. So here A and B are hypermobile EDS. So we see the scarring, they are abnormal, they are atrophic and widened scar. So this, after it healed like this as a wide scar, and the skin atrophied, this means it's thinned. And also here, but this is a patient with classical EDS, so it's more affected. This scar, it's more rough, it's more, we call it abnormal scarring. Okay, so these were like kind of introduction on a general review of the hypermobile and classical EDS. What about the bone finding? So bone finding is a kind of big description. When I'm talking about bone finding, I'm going to focus mainly about two features, which are the bone mineral density and fracture risk. So when I did the literature review with my supervisor to write a review about the bone finding in EDS, there were a couple of papers published, but they weren't easy to extract the data. Why? Because there are many types of EDS, and many papers, when they do the study, they don't specify what type of EDS the patients have. The scores to identify the bone mineral density were different among each center. So if you consider to have low bone density in one center, in another center with another numbers and guidelines, they have different, you might be normal. So that was something. So it wasn't really straightforward. I'll go through a few studies and the result of the studies, and we'll see how is that. But before we go, I'm going to explain a few terms. I know many of you might already know this, so I'm sorry if I'm just repeating it, but just to be all on the same page when I speak about bone mineral density. So this is a cartoon of a normal bone. So the bone, it has two types of bone. The one on the outer part, it's called cortical bone. So it's more solid. The one inside is called trabecular bone, and it has pores like the Swiss cheese, like the sponge. So this is kind of normal bone. When we have more holes and it's more porous bone, the bone becomes more fragile. So it presents, we call it osteoporosis. We have cutoffs to determine when is osteoporosis, when is a normal bone, and when is a hyperdense bone. And we have tools to measure this, the density of the bones. The most common one is being the DEXA, so it's the dual energy X-ray absorptiometry. So it's a two-dimensional X-ray that we can measure the bone density in many, well, basically we can do a whole body bone density, but the most common parts to measure the bone density are the head of the femurs. The femur is the bone of the thigh, and the lumbar vertebrae. So we have the vertebral column, we have the thoracic vertebrae and the lumbar vertebrae at the side of the back of the abdomen. So we measure the bone density in the 4 lumbar vertebrae, from lumbar vertebrae number 1, 2, 3, and 4. And then we have to plot it through graphs and to compare them to normal values to decide. So if it falls in the red zone, it's osteoporosis. If it's in the yellow, it's osteopenia, and if it's in the green zone, it's normal. Usually, as a rough estimate, we say before -2 to +2 Z-score is within normal range. And the Z-score is a value we give to determine how much is our value deviates from the mean value, from the normal mean values. Okay, so here are a few studies about peripheral fractures and bone mineral density in EDS patients. So there are a few systematic studies have investigated as I said, the bone mineral density and fractures. So one study, they compared the bone finding in 23 adults patients, and they have a control group. So they found that the EDS cohort, they have lower bone mineral density at both sides, meaning the femoral neck and the lumbar spine. And also the EDS group, they recalled having more history of having low impact fractures. But this is again a recall. So we just ask them, did you have more fracture? Did you have did you have many fractures? Like, oh yeah, you had fractures. So this is prone to recall bias. But again, the difference was significant. So 87% of patients with EDS recall they have sustained low trauma fractures versus 9% only in the control group. So individuals who does not have EDS. In contrast, in another study of 23 patients with hypermobile EDS, they did not find any difference in fracture history, but they had lower femoral neck bone mineral density than the control group. Another study in 39 women with hypermobile EDS or hypermobility spectrum disorder, they found that they have very similar bone mineral density in both sides, the head of the femur and the spine with the control group. But the fracture history was 3 times more in women with EDS. So as we see, these studies results are really non-homogeneous. So we cannot have a homogeneous conclusion that yes, for sure there's increased risk of fractures or there is decreased bone mineral density. Every study has kind of different conclusion, but we can know for sure that it has been reported that there is increased fracture risk and there is decreased bone mineral density. Okay, fun fact. So if you remember, we said in the classical EDS, 90% of the cases are caused by mutation collagen 5. There are some types of classical EDS when we have mutation in collagen 1A1. So clinically, it's still classical EDS. They have the clinical features of EDS, but the gene here, it's not collagen 5A1 or 5A2, it's collagen 1A1. So the collagen 1A1, it's the very well-known gene that causes osteogenesis imperfecta. Osteogenesis imperfecta is a disease of the bone. So patients, they have increased bone fragility and present with multiple fractures. They have blue sclera, they have dentogenesis imperfecta, so abnormality of their teeth, and they could also present with joint hypermobility, but it's not that significant. It's mostly a bone disease, but also it affects the joints and they could be lax. So there is an overlap between the Ellardano syndrome and the osteogenesis imperfecta. But in some cases, the Ehlers-Danlos clinical features are more prominent and is in a specific type of mutation, collagen 1A1. We diagnose them as having classical Ehlers-Danlos syndrome. But these patients, they've been reported that they have multiple fractures. Okay. So this concludes my findings in the common types of EDS, being the classical and the hypermobile. Now I'm going to talk about the more rare types of Ehlers-Danlos syndrome that have prominent bone findings. So the spondylodysplastic EDS. There are 3 genes that are known to cause spondyloplastic EDS. So 2 are enzymes, so galactotransferase 6 and 7, so beta 4 galactotransferase 7 and beta 3 galactotransferase 6, and solute carrier. So these are autosomal recessive, meaning we need to have to inherit one not working gene from the father and one from the mother, and to have them both mutated to present the condition. So this is a table of the clinical features of the 3 subtypes. So we call them Ehlers-Danlos syndrome, spondylodysplastic type 1, type 2, type 3. They all have short stature because this is mainly a bone disease. Type 1, they have developmental anomalies of the forearms and the elbow. They have bowing of the extremity and the classic stigmata of EDS, which are the joint hypermobility, the skin finding, and the tissue fragility. Type 2, they have more prominent also skin finding. They have aged skin appearance. They could have developmental delay. They could have facial dysmorphology. They do have low bone mineral density, generalized osteopenia. They have defective wound feeling, and of course the hypermobile joint. Also, they have hypotonic muscles, mean the muscles are more floppy and weak, and loose and elastic skin because it's still EDS. Type 3, they have again short stature, hyperplastic skin, hypermobile joint. They have protuberant eyes. I show pictures, and wrinkled palms. So as you see, there is overlap, but there are also slight difference between the 3 types of spondylodysplastic EDS. So fractures has been reported in, so the literature here, the studies I found that they have reported fractures in type 1 and type 2, but it doesn't mean that type 3, they don't have fractures. It just, these types are really rare. So most of our information, they come from case reports and case studies that they have few number of patients. So these are patients who basically they're 2 sisters. This is a very nice paper that explains all the rare types of EDS. And this is a patient of Dr. Roberto Mendoza. He's at Sick Kids, so this patient might be from Sick Kids. So if you see, I said they have facial dysmorphology. So they have micrognathia with this small chin. They have like protruded eyes, like, and this is so both sisters, they have the condition. And here the hand, it has increased creases of the skin and palm. Maybe the picture is not very clear, but it should have like more number and more prominent creases than usual. And they have club feet, so the foot is like inverted inwards. And so look at this picture. This is really impressive, and it tells us two things. This picture, it tells us the joints are really flexible, and the muscle tone is really low. So she's kind of floppy child, and she just folded herself. So this is kind of like one picture represent a lot of clinical findings. So at sick kids, they give candies to their patients. Okay. Uh, so this is about the spondylodysplastic EDS. The other type, it's called Kaifus Cholitic Eds. So Kaifu from kyphosis and scoliotic from scoliosis. So the scoliosis, it's when the spine, it has like S shape. So this we see it from the side. The kyphosis, it's the spine is like this. So this is lordosis and kyphosis. So they had Kaifus Cholitic. On two planes of the spines, they have abnormality. We have two genes that has been identified to cause Kaifus Cholitic Eds. We have the PLOD1 gene, so we call it PLOD1 related Kaifus Cholitic Ellardano syndrome, and the other one is called FKBP14 related Kaifus Cholitic Ellardano syndromes. I'll start with the FKBP14. So these are the clinical findings they have. So they have congenital muscular hypotonia. So congenital, it means it presents since birth. So the muscle has a low tone, that it's floppy. The children are born floppy because of this muscular defect. They have, again, congenital, meaning since birth or early onset kyphosis and scoliosis. So kyphos scoliosis, they have generalized joint hypermobility. They have early onset hearing impairment. So the one are in bold are more specific to the FKBP14 in comparison to the PLOD1. So they have early onset hearing impairment, muscle atrophy, and urinary bladder diverticula. They could have morphanoid habitus. Morphanoid habitus meaning they assemble patients of morphan. What does it mean? It means they are tall and have long limbs, and they have long faces and some specific also facial features. They have pictus deformity, so the chest, it could be pointed. It's called pictus carinatum, or it could be going inwards. It's called pictus excavatum. They have club feet. They have, again, because it's Ehlers-Danlos syndrome, they have skin hyperextensibility, easy bruising, hernias, sorry, because the tissues are lax. Rupture or aneurysm of medium-sized artery. They have blue sclera. Blue sclera is really a well-known clinical feature in osteogenesis imperfecta. So again, clinical finding overlap. They could have refractory errors, so visual defects that have myopia or hypertropia, and they do have low bone mineral density, either osteopenia or osteoporosis. The PLOD1, it's very similar again. They have congenital muscular hypotonia. It could be progressive or non-progressive. They have generalized joint hypermobility, dislocation, subluxation, and even of big joints, shoulders, hips. The hips are really big joints. So this is really impressive joint hypermobility. Skin hyperextensibility, skin fragility, rupture, aneurysm of medium-sized arteries. So aneurysm, it's the blood vessels are kind of dilated a bit. So this makes it, instead of being, let's say, like this, it's more dilated, and this makes it more prone to rupture. Again, osteopenia and osteoporosis, they could have blue sclera, hernia, pictus, morphanoid, club feet, refractory, microcornea, like just small cornea. So a lot of overlap with the other, it's the same clinical diagnosis. So this is a patient with PLOD1 related Kaifus Cholitic Eds syndrome. So here we can see, so this is the this is with FKBP14C. So he has severe kyphoscoliosis. So this is the kyphosis, and we can also appreciate a bit this scoliosis. And the pictures A and B, patient with plod 1, kyphus scoliosis. So this is the kyphosis, which is really impressive here. So this is a real patient. So this is my patient that I was following at McGill and Albert Shriners, who has Kaifus Cholitic Eds syndrome due to plod 1. So this is his X-ray and anterior posterior. So it shows the scoliosis, and it says here it's at 35 degrees, and it shows here on the lateral view the lordosis, and it shows another very, very interesting thing. It shows what we call vertebral compression fractures. So usually the vertebrae, let's say like this, they are nice cube-like structures, but here they are kind of crushed, and it's not because he fell on his back or something. We call spontaneous vertebral compression fractures. We see this very often in patients with osteoporosis and osteopenia. So the bone are so fragile that the vertebrae, they just crush. So this is an indication for receiving bisphosphonate treatment. And we started him on bisphosphonate treatment. So from our experience in osteogenesis imperfecta patients with osteoporosis and vertebral compression fracture, they respond very nicely to the bisphosphonate treatment. And as they are growing, they reshape their vertebrae. But this patient was already 14 when we started the treatment, so he might still reshape, but once we stop growing, it becomes more hard to reshape because kind of the bone, it stopped growing, but it's still a dynamic tissue. So we still give it to people after puberty, but the effect is really much more significant as the person grows. And this is a picture for the same patients for what it's called PQCT. It's peripheral quantitative computed tomography. So it's a three-dimensional imaging. It's like the CT, and it's very accurate, and give a very nice representation of the site. So this is control. So this is a normal patient. So this is the left arm here at this level. And this is the ulna, and this is the radius. Okay. So the more the redness, or the more the red the bone is, the more the bony material. So this is a nice radius. It has a Z score of plus 0.62, so it's normal. This is our patient radius. So there's minimal red there. So it means there is minimal bone material there. So it's almost a hollow radius. And he has this really low score of minus 4.7. And we said the normal, it's up to -2. What's below that, it's low. So he really had very low bone density. So again, that's an indication to start the vertebral compression fracture, and the osteoporosis was very strong indication to start him on bisphosphonate treatment. Okay. So this is a table we kind of gathered from the literature, mostly from the paper of Brady, to just summarize the bone finding in all types of Ellardano syndrome. It's a bit sad because you see we have a lot of blank spaces. It means we don't know. So I read it in so again, I don't have much to present because we don't have enough information in the literature. But the take-home message that because we don't know, we should offer more bone evaluation to discover if there is something that needs management or treatment. So we recommended doing in classical EDS, we recommended measuring the bone mineral density. In cardiovascular, we recommended measuring the bone mineral density. In arthrochalasia, we recommended doing bone mineral density and skeletal survey, meaning so skeletal survey is a series of X-ray that looks at many parts of the body. So it's usually 7, 11 like X-rays in one shot. Dermatopraxis, they do have history of fracture. They have, it means it has been reported before. So it has been reported before. They have fracture. They have low bone mineral density. So we recommended doing bone mineral density and spine X-ray. The Kaifus Cholitic Eds, both types we recommended doing the bone mineral density and the spine X-ray. The brittle cornea syndrome, they did have history of fracture and low bone mineral density, but it wasn't strong enough to really recommend that they have bone mineral density or spine X-ray evaluation. The spondylodysplastic, of course, it's a bone disease, so they should have skeletal survey and bone mineral density. The rest of the types we don't. So the musculocontractile, we recommended doing assessment of spinal deformity, but the rest we don't have specific recommendation and don't have enough information about the bone findings. One last thing, I kind of also spoke a bit about it when I talk about the classical Ehlers-Danlos. So we said that the Ehlers-Danlos syndrome, they could have increased bone fragility. The osteogenesis imperfecta patients, it's a bone disease, but they couldn't have joint hypermobilities. And in a big umbrella, they're both diseases. The osteogenesis imperfecta and the Ehlers-Danlos syndromes are considered connective tissue diseases. So there is overlap between both of them. Okay, so I have a question. I'll answer it at the end. Why we do not recommend bone mineral density and X-ray at the hypermobile type. I'll answer it at the end, sorry. Where am I? Okay, so in some cohort of patients, they have clinical features of both osteogenesis imperfecta and Ehlers-Danlos syndrome. But they have a bit of both. It's not enough to diagnose them with OI only or EDS only. So there is a new category called OI EDS overlap syndrome. There's a bit of controversy on this. Do we really need to name it as as like a separate identity? Why it shouldn't be either EDS or OI? And we know already they have overlapping features, but you will find a lot of papers about OI EDS overlap syndromes. Most of the cases are caused by collagen 1A1 or collagen 1A2, which is known to cause osteogenesis imperfecta, but these patients have more EDS clinical features, so they decided to name it OI EDS overlap syndrome. Okay, so what's next? So what do we learn from all that? Well, we have too many types that we don't have a clear conclusion, but we know that they could have osteoporosis and low bone mineral density. So bone mineral density varies widely among the different types of EDS. Low mineral density is known to be low, so it's considered as a feature in Kaifus Cholitic Eds, arthrochalasia, spondylodysplastic, and classic-like EDS. In hypermobile and classic, there are some reports of mildly decreased bone density. It's not clear that fracture rates are really increased. So what do we recommend? We recommend performing spine radiograph and bone mineral density at diagnosis. Well, I'm a bone person, so if I have a new patient with EDS, I would offer him bone mineral density and spine X-ray, but this might not be available in every center, or so we cannot at this point, we cannot really make it like, yeah, you should do it because so and so. But it's really, if I have a chance and to do it, I would do it, because if we don't do it, we'll never know. And patients with vertebral compression fractures may be candidate for bisphosphonate treatment, like our patient with Kaifus Cholitic Eds. And there are also few reported cases in the literature about patients with spondylodysplastic EDS who received the bisphosphonate treatment. And please, please, please do not forget your vitamin D. Vitamin D is great, is important, is your good friend. It's available, it's over the counter. It comes in many flavor or flavorless or drops or liquid or gums or with chocolate, with strawberry. Just choose your type. Please take your vitamin D. Unless you really take 2 to 3 portions of dairy per day, which is not very common with our nowadays diet. So, or you're living, I don't know where there is sun 12 months per year and you live by the beach and you don't need vitamin D. But if you live in Canada and it's really snowy and there is not enough sun and you don't need enough milk, which is most of us, please, please, please take your vitamin D. I didn't put a specific dose because every guidelines has different dose and because everybody had different metabolism of vitamin D. But please take it. And thank you. So these are my references. And before I finish my talk, I would like to recommend some websites about Ellardano syndrome. So of course, the RQMO, they are really doing amazing job about finding nice literature and presenting them to the patients and connecting patients together and finding the resources for patients in Quebec to go to and translating a lot of papers and talks. We really appreciate what they do. Another very, very nice website, the Ellardano Society website, is a huge website, and they have tons of talks and events and literature, and there is something for everyone. It's like a big yard sale, something for everyone. There are for healthcare professionals, there are for patients and family, and now they even have live chats. They have like webinars, they have conferences. It's an amazing website. There's another Canadian website. It's not only specific for EDS, it's for chronic pain, Ehlers-Danlos, and connective tissue disorders, called the ISC Foundation. I also recommend that you go have a look at it. They have, you see, very coming soon, November 7th, in a few days, conference, but it's about pain. It's not specifically about Ehlers-Danlos, but sometimes they do some events about Ehlers-Danlos. And thank you. I'll open now.
All right.
The
So
questions. Yeah.
thank you so much for this presentation. As we discussed, we're going to be having a question period now. What we're going to do is we're going to ask them in English so that we can keep things simple from a translation standpoint, not going back and forth.
Oh, it's fine. They can write them in French. It's fine.
Well, it's just because for the simultaneous translation, so it doesn't get all lost somewhere. So why not recommend DMO or RX in hypermobile types is our first question.
Yeah, it's not, I do not recommend, or I do recommend it. It's the hypermodal, as we said, it's very, very common. And it depends on if they have bone finding, or they have bone pain, or they have history of fracture, or it's available in the facility to do it. So usually at the Shriners, I'll do it for my patients, but it's not something that's available everywhere. So at this moment, it's not yet a recommendation, like a strong recommendation to do it for each and every patient with EDS, but it doesn't mean that we don't need to do it. As we saw from the literature, it's still overall, and we don't have strong conclusion that you really need to do it. But if you can do it, yes, go for it. And the other thing, okay, if we do it, how it's going to change our management. So if I ask every family doctor patient to do it for its patient, said, okay, how it's going to change my management? So if they're not candidate for bisphosphonate, or that's usually what we give. So just take your vitamin D, take care of yourself. And it's not I'm saying we don't need it, but I don't think now we have enough evidence and enough it's like it's facilities to have it done for each and every patient with EDS.
All right, thank you. Our next question. It seems to be more of a case study again. Oral biphosphonates cause the patient GI bleeding, more bleeding with each dose. Suggestion is to do biphosphonate infusions. Patient has had one mild vertebral compression fracture at age 49, 3 other fractures prior. Currently, the patient is over 60 years old with no more recent fractures. Current diagnosis is bone fragility, not osteopenia. The patient has some sort of heritable connective tissue disorder, possibly Loeys-Dietz. Would you recommend biphosphonate infusion? I think you can find it written down if it was a long question. If you want to read it for yourself. So in short, I guess it was causing GI bleeding.
Yeah. Well, to be honest, I'm not an endocrinologist, so I'm a geneticist. So usually at this age, we refer them to endocrinology. So my honest answer is I don't know. I would consult an endocrinologist. Like other Shinas, we give it because it's part of the center to give it to children. But for adults, we always send them for endocrinologists to give the treatment. So I don't know. I'm sorry.
And we have
My
another
humerus. Okay. Did you?
Oh,
did
go
they hear
ahead.
the answer for that?
Pardon
Okay.
me?
My humerus. Are we done with the second question?
Mhm.
Okay. My humerus fracture that should have healed in 12 weeks took 20 months. I have headaches. Is that typical of EDS? I have had many fractures, refractures, delayed healing always. Well, you could have it or you could not have it. I recommend that you see a doctor to have a clinical evaluation. Like I cannot give a diagnosis on this webinar, and you need a like full clinical evaluation and physical exam. Ma fille est de 13 ans, score 7 sur 9, a des douleurs en genou, je vais...
So my 13-year-old daughter has a score 7 on 9, has hip pain, knee pain, ankle pain, has a labrum tear, angulation in the coccyx, and we don't want to give her a diagnostic despite many EDS symptoms. She has done a test, a couple of genes, and it came back with a mutation in the Notch1. And what does that mean?
Let me see, the Notch one, which one is that? Well, I'm not supposed to give clinical advice on the on webinars. But who ordered the genetic testing should follow on that, because I'm not supposed, sorry, to give clinical advice or diagnosis like for specific cases on webinars.
All right. Is it possible to have fibromyalgia and have HEDS?
Well, it's all like, if they're not mutually exclusive, you could have two diagnoses at the same time, but many cases it's just the fibromyalgia gets misdiagnosed with EDS, but I don't see why you cannot have them both.
All right. What do you think of the controversy around babies and children with fractures, but parents accused of causing them, but EDS was found in one parent and family? It can be possible. We all know that rare is possible. So I think this comes back
Well,
probably.
there was a big study. There was a big study. I didn't mention that in my talk, but I'm very glad this question was brought up. There was a big study in the States that were trying to find that babies with fractures because of what's called now trauma X, it's because of their EDS. So they found that, like, they followed them and they grow and they had the diagnosis of EDS. Patients with EDS, they didn't have fractures in their first year of life. So babies with fractures, EDS is not a culprit. Like, that's from what we have from the literature. It might change the future. That's what we know for now.
All right. I saw participants has raised hands. If it was for questions, can we try and put them into the Q&A box just to make sure that it is indeed a question you wanted to ask? And as a reminder, Dr. Basalom cannot give necessarily medical advice during the webinar on specific
Yeah,
cases.
for
Those
specific
are best
cases.
integrated with your own care team as much as possible. Perhaps we'll wait another couple of seconds. Here we are. Do all the EDS types have bone manifestations?
Well, we don't know. If we can go back to that table. So this is what we know so far. Let me enlarge it. So this is all the types of EDS, and this is what we know. Some have fractures, some have low bone mineral density, but these are based on all the information are available in the literature. So we don't know more than we have for now. So many of them have. Does all of them? It seems that not all of them, but we don't know because we don't have enough information. It doesn't mean that because it's not there.
Thank you.
That's it.
I think that's about it. Oh, there we go again. Do you know if International Registry is collecting data on bones?
I don't know. That's a good question. I would look it up, and I don't know how do I leave my email at the end. That's a good question. I have to look it up.
And perhaps we will see if there's a way of maybe broadcasting the answer to that at a later date.
Yeah, that would be great.
Yeah, thank you. Final boarding call for questions. Oh. Other than vitamin D for the bones, is there exercises for stability that are good to reinforce the muscles and the bones?
Of course, because the muscle and bones are like, they work together. If you have a better muscle strength, you have a better bone. If you have weak muscle, you have weak bones. What exercises specifically, that I don't know. That's a physiotherapy sport thing, but I can tell you for sure, if you exercise, you have better muscle and you will have better bones. Sorry, can we go back to the international registry collecting data, meaning, of course, bones finding in EDS patients, right? Not generally.
Yeah, I would assume that was I would assume that was the question, yeah. Yeah, that's right. It was for the EDS patients.
Okay.
So we have a question/comment that you need impact on bigger bones, like walking, jumping, to prevent osteoporosis. What would you say on that?
Walking and jumping.
Yeah.
You know, it's walking is good. Jumping, I don't know, depends on the type of jumping. But generally speaking, exercise and having sport and having healthier lifestyle, for sure, it will have a better muscle and bone health. But to prevent, that's if you have bone fragility predisposition, no matter what you do, you will still have it. That's so it's good to do it, but again, genetics also play a role.
Okay. If you're taking vitamin D, isn't it important to also take vitamin K to direct the increased calcium to the bones?
No, we don't. Vitamin D is enough. Sometimes we recommend vitamin D and calcium, but I would say vitamin D is enough. We don't recommend vitamin K with vitamin D.
So the best way so far to get more questions is me saying that we seem to have no more questions, that we're getting ready to wrap up. So let's try it one more time. It seems we've run out of questions.
We can post also we're gonna post the talk on the website, right?
Exactly, yes.
Yeah, I can send you the PowerPoint also, you can post it.
Yeah, so the recording of the session with I guess the video, the presentation, and also the audio is going to be available on our website. I think most likely there's going to be an email sent out within the next month with a link to it. Otherwise, it's also available on our website, which I believe you will be redirected to at the end of this presentation.
Okay.
So on that, if we have no more questions, I think it concludes today's webinar on the orthopedic manifestations of Ellardano syndrome. Thank you so much, Dr. Basalom, for joining us today, for presenting all this and teaching us so much. Thank you for answering all these questions. Also, there were many, many questions, very, very interesting questions. So thank you all for joining us. Please join us for our upcoming webinar on the rare disease strategy in early December. At the end of the presentation, as I was saying, you'll be redirected to the RQMO website, so you can sign up for our email newsletters, connect with us on Facebook, access recordings to previous webinars, and also make a donation to support our mission if you are willing. Thank you so much for joining us. Merci beaucoup. Bonne journée à tous. Et à la
Thank you
prochaine.
for having me, and thank you everyone for being there. Bye. Thank you. Bye.